Hello, everyone. Welcome to another edition of Hematology and Blood Transfusion Science Lecture Series with Dr. Ifeoma Mary and Okafor. This is a YouTube channel where we discuss different topics in hematology and blood transfusion science. For some time now, we have been having lecture series on hemostasis, and today we are continuing with that lecture where we'll be handling specifically a topic tagged thrombosis and antithrombotic therapy. Thank you very much for supporting us. Thank you for subscribing to our channel. And if you have not subscribed yet, this is the right time to subscribe. Please don't hesitate to hit the button now. Let us go straight to today's lecture. Learning objectives. By the end of this lecture, you should be able to explain the pathogenesis of thrombosis using Virchow's Triad, distinguish arterial, venous, and microvascular thrombi by features and causes. You should be able to identify clinical presentation of venous thromboembolism and outline key laboratory tests for thrombosis and interpret common results. You should be able to summarize principal indications, monitoring, and complication of antithrombotic therapies. Let us start by defining thrombosis. Thrombosis is the pathological formation of a blood clot, which is known as thrombus, within a blood vessel, obstructing the normal flow of blood. It can occur in both arteries and veins, leading to various clinical manifestations depending on the location and the extent of the clot. When a thrombus dislodges and travels through the circulatory system, it is called an emboli. Thrombosis is a pathological manifestation of hemostasis, and we have been discussing hemostasis, the primary hemostasis, the secondary hemostasis, the fibrinolytic system. Thrombosis is a pathological manifestation of hemostasis. Thrombosis occurs when the delicate balance between procoagulant and anticoagulant forces is disrupted. What are the causes of thrombosis? Now we have what we call the Virchow's Triad. The fundamental causes of thrombosis were first described by Rudolf Virchow in 1856 and are collectively known as Virchow's Triad. This triad provides a framework for understanding the pathophysiology of both arterial and venous thrombosis. And these are endothelial injury, stasis or turbulent blood flow, hypercoagulable states or thrombophilia. So we have Virchow's triad as number one, endothelial injury, number two, stasis or turbulent blood flow, number three, hypercoagulable states, or what we call thrombophilia. Let's have a closer look at the different causes of thrombosis. First one, remember we are talking about the Virchow's triad, which describe three causes of thrombosis. We have number one, the endothelial injury, stasis or turbulent blood flow, and now thrombophilia. Now we're starting with endothelial injury. Damage to the vascular intima is the dominant factor in endothelial thrombosis. It exposes subendothelial collagen, von Willebrand factor, and both collagen and von Willebrand factor are highly thrombogenic. And also, damage to the blood vessels also exposes tissue factor. And all these things help to do what? To activate platelets and also coagulation cascade. Examples is when you have atherosclerosis, trauma, surgery, cannulation, vasculitis, inflammation, hypertension, indwelling catheters. Now, when you have this atherosclerosis, what we have what we call atherosclerotic plaque. And when this atherosclerotic plaque ruptures, what happens? You have platelet-rich arterial thrombus in the blood vessel. Let us now look at the second cause of thrombosis, and we have stasis or turbulent blood flow. Stasis or turbulent blood flow. Abnormal blood flow prevents the normal dilution of clotting factors and inflow of natural inhibitors. Abnormal blood flow prevents the normal dilution of clotting factors and inflow of natural anticoagulants. Now, what is stasis? Stasis can just be described as a slow or stagnant flow. A slow and stagnant flow in the blood vessel allows for accumulation of activated clotting factors and platelets, particularly in the low pressure venous system. Now let's look at turbulence. What is turbulence? We can just say it is chaotic or non-laminar flow. Then when you have chaotic or non-laminar flow within the blood vessels, it can damage the endothelium. It can also activate platelets and clotting factors. And this is often seen in the high pressure arterial system at the sites of bifurcations or stenosis. We have examples when you have prolonged immobility, like long flights or bed rest, or post-operative, those that have surgery and been instructed to rest after operation. And then you have heart failure, pregnancy, obesity, arterial fibrillation, and venous valve damage. Now, venous stasis can be attributed to immobility, long flights, and then long surgery or heart failure. And it predisposes to fibrin-rich red venous thrombi, formation of fibrin-rich red venous thrombi. When you have turbulence in arteries, like in cases of aneurysm, atherosclerosis, it predisposes the patient to having his own platelet being activated. So we have the second cause of thrombosis being what? Stasis or turbulent blood flow. The third cause of thrombosis, according to Virchow's Triad, is hypercoagulable state or thrombophilia. This refers to an increased tendency for blood to clot due to an imbalance in the procoagulant and anticoagulant system. It can be acquired, it can also be inherited. Acquired when it occurs in cases like cancer, pregnancy, use of oral contraceptives, or hormone replacement therapy, obesity, or in the presence of inflammatory diseases, nephrotic syndrome, antiphospholipid syndrome, heparin-induced thrombocytopenia, and smoking. It can also be inherited when there is mutations in some clotting factors such as factor 5 leading and prothrombin gene mutations. You can have a patient having hypercoagulable stage or thrombophilia, predisposing the patient to thrombotic disorders or having what we call thrombosis. There are different types or classification of thrombosis, and they are classified using different categories. And we have the first classification based on by composition or location where the thrombus is formed. Okay? The first classification we are going to consider is classifying thrombosis based on the composition and the location. So the first one we have is what we call arterial thrombus. Arterial thrombus. The pathology is typically initiated by the rupture of an atherosclerotic plaque leading to a white thrombus, primarily composed of platelets with a small amount of fibrin. It occurs under the high flow condition. So with the first type of thrombosis that we are considering, and it is the classification is based on the composition and location of the thrombus. Is number one what? Arterial thrombus. And this arterial thrombus is initiated by the rupture of an atherosclerotic plaque. When atherosclerotic plaque ruptures within the blood vessel, it leads to the formation of what we call white thrombus. And this white thrombus is mainly composed of platelets with a small amount of fibrin, and it occurs under high flow condition. So we have composition, white thrombus in cases of arterial thrombus, and they are platelet rich with fewer red blood cells. Pathophysiology, it is actually formed primarily as a result of endothelial injury. Example, ruptured atherosclerotic plaque. And then clinical consequences. The thrombus, when it's in the coronary artery, can cause myocardial infarction. When it is found in cerebral artery, can also cause ischemic stroke, and it can also cause peripheral arterial disease when the thrombus is found in the arteries of the limbs. So these thrombus, when they dislodge and they are found in the coronary artery, they can cause myocardial infarction. When they are found in cerebral artery, they can cause ischemic stroke. And when they are found in the arteries in the limbs, they can cause peripheral arterial disease, PAD. Then we have another classification of thrombosis based on the composition and location. The second thrombosis is what we call venous thrombus. Venous thrombus. This is often initiated by blood stasis and hypercoagulability, leading to a red thrombus, which is rich in fibrin and trapped red blood cells. It forms in low flow and low pressure venous system. Composition of venous thrombus. Venous thrombus, unlike arterial thrombus, is called red thrombus. Remember, arterial thrombus is called white thrombus because it is rich in platelets and low in fibrin. While the venous thrombus is called red thrombus because it has a lot of erythrocyte, that is red blood cells. So it is erythrocyte rich, fibrin rich with a smaller platelet composition. Pathology, it primarily occur, venous thrombus primarily occur as a result of stasis, okay, and then hypercoagulability. Clinical consequences, it can lead to what we call deep vein thrombosis. Deep vein thrombosis. Deep vein thrombosis is a clot in the deep vein, most commonly in the legs and pelvis. The primary risk is the detachment of the thrombus and then forming an embolus, which can lodge in any part of the system. And then we have the second one, pulmonary embolism. Pulmonary embolism is a life-threatening condition where a deep vein thrombus embolizes to the pulmonary arteries, blocking blood flow to the lungs. Other sites that it can also affect that can be affected are the portal vein, the renal vein, and the cerebral venous sinus thrombosis. So venous thrombus, unlike the arterial thrombus, are called red thrombus because they are rich in a red blood cell and they are rich in fibrin, but they are low in platelets. Why the arterial thrombus are called white thrombus because they are rich in platelets and low in fibrin and very low in red blood cells. We have another classification of thrombosis based on the clinical syndrome. Based on the clinical syndrome. And the first one we have here, what we call venous thromboembolism. Venous thromboembolism are made up of deep vein thrombosis and pulmonary embolism. Deep vein thrombosis and pulmonary embolism. And then we have another one, arterial thromboembolism. Arterial thromboembolism is acute coronary syndrome like stroke, acute limb ischemia, and then we have microvascular thrombosis. So classifying thrombosis based on clinical syndrome, we have venous thromboembolism, which is made up of deep vein thrombosis and pulmonary embolism. We have atrial thromboembolism, and then we have microvascular thrombosis, which is mostly seen in disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. We can also classify thrombosis based on pathogenesis. Pathogenesis. So classification by pathogenesis, we have provoked and unprovoked. Provoked venous thromboembolism, that is under provoked, we can talk about transient. That is, when we say provoked, they are transient. That is, we have example venous thromboembolism that is instigated as a result of surgery, trauma, immobilization, pregnancy, hormonal therapy. Or we have unprovoked venous thromboembolism. In this particular case, there is no clear transient cause. Okay, and then it has higher recurrence risk. And then we have recurrent or chronic thromboembolic disease. Recurrent or chronic thromboembolic disease. Example, we have chronic thromboembolic pulmonary hypertension, chronic thromboembolic pulmonary hypertension. So you can classify thrombosis based on their pathogenesis, and we have provoked, transient venous thromboembolism, we have unprovoked venous thromboembolism, and then we have recurrent or chronic thromboembolic disease, which is example of it is chronic thromboembolic pulmonary hypertension. Now, we also do classification based on histology or age. And in this case, you just have acute or organized or chronic thrombus. Acute or organized or chronic thrombus. And this type of classification is important for imaging or intervention planning or for pathology. Now let's have a closer look at clinical features and pathology. Clinical features of various thrombotic disorder that we have mentioned. The clinical features of thrombosis vary widely depending on the location and then the size of the clot. The symptoms are a direct result of tissue ischemia and obstruction of blood flow. So we have in deep vein thrombosis. Remember that deep vein thrombosis is also an example of venous thromboembolism. So venous thromboembolism, we have two pathological conditions under it, deep vein thrombosis and pulmonary embolism. So we are looking at deep vein thrombosis. Deep vein thrombosis, the site is, as indicated in the diagram that you are seeing here, is on the leg. The site most commonly in the deep veins of the leg. And then the symptoms and the size is mostly unilateral leg swelling, pain, tenderness, warmth, or erythema. And then you have what we call the Homer sign, which is pain on dorsiflexion. But this is very, very unreliable and most times not recommended. Then pathology, obstruction of venous outflow leads to increased hydrostatic pressure, causing edema and inflammation. And then the major risk is embolization to the lung. When the thrombus dislodges and then causing an embolus and then gets to the lung, it can cause pulmonary embolism. And then post-thrombotic syndrome, that is chronic venous insufficiency. So the major risk is embolization to the lungs and then post-thrombotic syndrome, that is chronic venous insufficiency. Then we have pulmonary embolism. Pulmonary embolism. This is embolus that lodges in the pulmonary arterial circulation, causing ventilation perfusion, mismatch, increased pulmonary vascular resistance, and then right heart strain. Variable obstruction of pulmonary arteries and leads to increased right afterload and then right ventricular dysfunction. That is hypoxemia. Symptoms, we have like small pulmonary embolism and then massive pulmonary embolism. In the small pulmonary embolism, we have a prolactic chest pain, which is sharp pain with breathing, cough. Sometimes it comes with blood tinged with sputum, what we call hemoptysis. And then we can also have dyspnea, sudden onset of shortness of breath. In small pulmonary embolism, you can have prolactic chest pain, which is sharp pain with breathing. You can have cough. Sometimes it comes with blood and tinged with sputum. That is what we call hemoptysis. And then you can have dyspnea. And then we have massive pulmonary embolism. Massive pulmonary embolism is a medical emergency because it can cause sudden collapse, severe dyspnea, tachycardia, and hypotension. Arterial thrombosis. Arterial thrombosis, we have like coronary artery, what we call myocardial infarction. Myocardial infarction, you have this crushing or squeezing chest pain that may radiate to the arm, neck, or jaw, shortness of breath and sweating or nausea. And then in cerebral artery, you have like ischemic stroke. We have sudden facial neurological deficit, and then sudden weakness or numbness on the one side of the face, arm, or leg, slurred speech and vision changes, and severe headache. And then you can also have peripheral artery, that is acute limb. We have microvascular thrombosis or disseminated intravascular coagulation. This one is increased consumption of clotting factors and platelets. Pathology of thrombosis. Pathology of thrombosis is a complex interplay between platelets, the coagulation cascade, and the vessel wall. Pathology of thrombosis is a complex interplay between platelets, coagulation cascade, and vessel wall. We have number one, arterial thrombus formation. What is the basic pathology for arterial thrombus formation? Number one is atherosclerotic plaque, which ruptures and exposes tissue fracture. And then when it ruptures, platelets will adhere to it, activate and aggregate, bringing other platelets together to form the primary platelet plug. And then the coagulation cascade is triggered, generating thrombin, which converts fibrinogen to fibrin, stabilizing the clots. And when this ruptures, you now have these platelets coming, forming what we call white thrombus, which is made up of what? Platelets, it's rich in platelets, and then fibrin, but very low in red blood cell. Then we have venous thrombus formation. Venous thrombus formation occurs as a result of blood stasis that leads to the accumulation of activated clotting factors. The intrinsic coagulation cascade is initiated, leading to a massive generation of thrombin and subsequent fibrin formation. The loose fibrin mesh is actually what comes together, trapping red blood cells to form, trapping the red blood cells to form the red thrombus that is rich in erythrocytes and also fibrin, but very low in platelets. So pathological composition difference between arterial thrombus and venous thrombus. Arterial thrombi is platelet rich, white thrombi, which occurs in high shear platelet activation, while the venous thrombi is fibrin and red blood cell rich, and red thrombi, which occurs in low shear and stasis. This explains why antiplatelet drugs are mainstay in arterial disease, while anticoagulants are central in venous diseases. Laboratory diagnosis and investigation. How do we diagnose thrombosis in the laboratory? We start by doing full blood count, or what we call complete blood count. And platelets, when we are doing full blood count, our focus is mostly on the platelets. Thrombocytosis may predispose, while thrombocytopenia may exclude some therapies. And then we look at coagulation screen, where we do prothrombin time test, international normalized ratio, activated partial thromboplastin time test, and then you can baseline test before anticoagulation or to dictate coagulopathy or disseminated intravascular coagulation. And then D-dimer test is also done. This is also sensitive but not specific for deep vein thrombosis, and are usually used to exclude venous thromboembolism in low pretest probability. We have diagnostic tests that can also be done fibrinogen or fibrin degrading product assay, cardiac markers assay like for example troponin and B5 natriuretic peptide, and then thrombophilia testing. Thrombophilia testing is reserved for selected patients that are example patients that are young, below 50, with unprovoked recurrent venous thromboembolism. Now, laboratory diagnosis for suspected venous thromboembolism (VTE), you use there are some validated scores like Wells score that can be used to diagnose deep vein thrombosis and pulmonary embolism. The Wells score is a clinical prediction tool used to estimate the probability of deep vein thrombosis or pulmonary embolism before ordering other tests. It assigns points for risk factors and clinical features, example, recent surgery, cancer, leg swelling, hemoptysis, and tachycardia. The total score classifies patients into low, moderate, or high probability, or likely or versus unlikely. So the clinician uses the Wells score to first of all classify the patient that is suspected of having either deep vein thrombosis or pulmonary embolism. Okay, this Wells score is actually a clinical prediction tool that can be used to estimate the probability of a deep vein thrombosis or pulmonary embolism in a patient before ordering for other laboratory tests. It's just a science score. You can just assign score by measuring some clinical features like recent surgery, cancer, leg swelling, tachycardia, and others. You can now say assign scores like low, moderate, or high probability. You can also use words like likely or unlikely to, you know, define whether the person might be having either deep vein thrombosis or pulmonary embolism. Now, this well score help guide the next step, like low probability plus negative D-dimer excludes deep vein. When you have the clinician must have done the well score and maybe he has low probability and he has done a D-dimer test and it comes out negative, then it excludes deep vein thrombosis and pulmonary embolism. And then if the patient has high probability, and then what happens is now proceed directly to imaging. Well score is a bedside tool to assess pre-test probability of venous thromboembolism, that is in cases of suspected deep vein thrombosis and pulmonary embolism. Then for suspected venous thromboembolism, remember for after doing the well score, you can now order D-dimer test. Remember that D-dimer is a fibrin degradation product. The D-dimer has high sensitivity in diagnosing venous thromboembolism but low specificity. D-dimer has high sensitivity, like 95% sensitivity, but low specificity. So a negative D-dimer in a patient with low pretest probability effectively rules out venous thromboembolism. So a negative D-dimer in a patient with low pretest probability effectively rules out venous thromboembolism, while a positive D-dimer test is non-specific and requires further investigation, as D-dimer can be elevated in many conditions, example infection, surgery, cancer, and pregnancy. So a positive D-dimer is non-specific. Remember I said that D-dimer test is highly sensitive but has low specificity. So a negative D-dimer in a patient with low pretest probability effectively rules out VTE, that is venous thromboembolism, while a positive D-dimer test is non-specific, but it can also go on, requires further tests to do what, or further investigation like imaging to confirm the diagnosis. Imaging studies that can be done to also help to confirm the diagnosis is duplex ultrasound, CT pulmonal angiography, electrocardiogram, ECG, echocardiogram, and then magnetic resonance imaging. Dis all can be done in addition to D-dimer test and then using the Wells score to do what? To diagnose dem venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. Thrombophilia screen. Dis include a series of blood tests to identify inhibitors in acquired hypercoagulable states. Includes tests for factor V Leiden, prothrombin gene mutation, anticoagulant protein C and S deficiency, antithrombin deficiency. These are usually performed after the acute thrombotic event has been treated and only if clinically indicated, especially example in recurrent thrombosis. Thrombosis at a young age for people that are below 50 years, and also the people that have strong family history. When do you carry out this thrombophilia screen on a patient? It is not routinely done, and it is considered in unprovoked venous thromboembolism, venous thromboembolism at unusual sites, people that have strong family history, or people that have recurrent venous thromboembolism, and venous thromboembolism in young patients that are below 50 years. Now, what to test? Timing is very critical. Timing is very critical. Do not test during acute thrombosis or while patient is on anticoagulant. This thrombophilia test should not The test should not be done during acute thrombosis or while on anticoagulant. Now, the test is the first line for diagnosis of factor V Leiden, prothrombin G2021A mutation, and is a second line test for diagnosis of antithrombin, protein C, protein X activity levels deficiency. Remember that the levels of these things are falsely low when the patient is on warfarin. Laboratory diagnosis of antiphospholipid syndrome. Antiphospholipid syndrome actually requires persistent testing of thrombophilia screen for at least greater than 12 weeks of lupus anticoagulant, anticardiopulin or anti-beta-2 glycoprotein 1 for diagnosis. In antiphospholipid syndrome, direct oral anticoagulants are not preferred for high-risk patients with arterial events or triple positivity, and warfarin usually recommended. For arterial thrombosis, focus is on identifying the source, example the plaque, and then the risk factors. The laboratory test that should be done is lipid profile, glycolylated hemoglobin, inflammatory markers, and then ECG for cardiac markers, echocardiogram, and then the imaging, CT/MR, angiography, and then Doppler ultrasound. Antithrombotic therapy. Antithrombotic therapy aims to prevent or treat the thrombosis, reducing the risk of complications like stroke, heart attack, and pulmonary embolism. The goal of treatment is to prevent clot extension, embolization, and reoccurrence while minimizing the risk of bleeding. Main modalities are anticoagulation, thrombolysis, catheter surgical thrombectomy, filters, compression therapy, and secondary prevention. The treatment include the use of antiplatelet agents. Antiplatelet agent is used primarily for anterior thrombosis, which has which is platelet rich. Antiplatelet agents are mostly used for anterior thrombosis, which is platelet rich. And then these antiplatelet agents are number one, aspirin, P212 inhibitors, glycoprotein 2b3A inhibitors, which are glycoprotein 2b3A inhibitors actually block the final common pathway of platelet aggregation, preventing platelet aggregation. So, the treatment includes the use of antiplatelet agents in the arterial thrombosis, and the antiplatelet agents include aspirin, P2Y12 inhibitors, glycoprotein 2b3A inhibitors. Then the use of anticoagulants. The use of anticoagulants are mostly done in venous thrombosis, and it is used in preventing embolus, conditions like arterial fibrillation. They inhibit the coagulation cascade to prevent fibrin formation. You can have parenteral anticoagulant like unfractionated heparin and then low molecular weight heparin. Unfractionated heparin and low molecular weight heparin. Then we have oral anticoagulant. Oral anticoagulant like vitamin K antagonist, warfarin, can also be used. Then direct oral anticoagulant. These are newer agents and have a more predictable effect and don't require routine monitoring. And then we have direct activated factor 10 inhibitors and also direct thrombin inhibitors that can also be used in the. And then we have thrombolytic therapy or fibrinolytic therapy. These agents actively break down existing clots by converting plasminogen to plasmin. It is used in life-threatening situations like massive pulmonary embolism, severe deep vein thrombosis, and acute myocardial infarction to restore blood flow immediately. This therapy carries a high risk of major hemorrhage and is reserved for specific high-risk patients. There are also special consideration where if it is cases where cancer-associated thrombosis or antiphospholipid syndrome and heparin-induced thrombocytopenia, there is special consideration that should be done in cases of treatment so that the patient is properly treated. Then we have surgical interventions like catheter-directed thrombolysis, thrombectomy, and inferior vena cava filters. Catheter-directed thrombolysis is delivering a thrombolytic agent directly to the clot, and then thrombectomy is mechanical removal of the thrombus, and then inferior vena cava filters is placed in the inferior vena cava to trap emboli and prevent them from reaching the lungs. It is actually used for patients with DVT who cannot be safely anticoagulated. Thrombosis is a serious condition caused by factors such as endothelial injury, hypercoagulability, and stasis, and clinical features vary based on location, and laboratory diagnosis is essential for proper treatment. Antithrombotic therapies, including anticoagulants and antiplatelet agents and thrombolytic agents, are key in the treatment. These are my references. Thank you very much. I hope you have learned something. Keep a date with us as we come back next time with another exciting topic. Keep a date with us as we come back next time with another exciting topic. Thank you very much. And thank you. Please don't forget to subscribe and also share our videos. Thank you and thank you.